This is Dr. Hunter Green. We will be doing a surgical technique video for STRYKER's VersiTomic and RR, an all-inside ACL reconstruction technique. We begin by placing the femoral guide into the knee. You can recreate the femoral-sided footprint of the ACL with this guide. It will allow you to measure the interosseous length of your tunnel from the notch to the lateral femoral cortex. With this guide in place, you will need to insert the bullet against the cortex and begin your reaming with the VersiTomic RR. This is a retrograde reaming technique that utilizes a tooth on the reamer to do the retrograde reaming. When inserted into the joint, you will note that there's a black line on the reamer. This has to be visualized before you begin your reaming. Reaming is done in reverse in a slow, controlled fashion. The bullet is tapped into the cortex to provide stability. Once you reach the cortical bone with the notch, you can use the grommet so you can measure your length of the tunnel on the femoral side. This is done in 5mm increments. You can estimate the length as you withdraw the reamer. Next, there's a K-wire of the reamer that is removed to allow placement of the nitinol wire through the center cannulated portion. This is captured with a grasper and brought out through the anteromedial portal. The bullet guide can be removed at this point and will go to the tibial side. An oval loop guide is used to recreate the tibial-sided footprint of the ACL. The reamer is advanced into the joint at this point. Once again, making sure that black line is visible before we begin reaming. Once you're satisfied with the placement within the joint, you may remove the interarticular guide. You want to secure the bullet into the tibial cortex by lightly tapping on it. Once again, our black line is visualized before we begin our retrograde reaming. It is important to remember to ream in reverse in a slow, controlled fashion. We're advancing the grommet at this point to make sure we have our tibial tunnel length appropriate. Once we've reached our appropriate depth, we advance the reamer back into the joint. At this point, we will be unchucking the drill from the reamer. We will be removing the center K-wire from the reamer. This will allow us to pass our nitinol wire up into the joint space. But first, we must clear some soft tissue so we can better visualize the wire coming out of the reamer. This is an important step to make sure we have clear visualization of the wire coming into the joint space. We've slightly withdrawn the reamer so we can allow the clearance of the soft tissue. It is important to make sure we have circumferential clearance of the soft tissue from around the reamer. Now we begin to pass the wire up the cannulated portion of the reamer. Once we see the wire within the joint space, we will capture it through the anteromedial portal. We may now remove the reamer from the tibial tunnel. Securing the wire at the anteromedial portal. Our next step will be to place a gateway cannula in the anterior medial portal to allow smooth transition of the graft into the joint space. The gateway cannula is placed into the anterior medial portal. Both wires have been withdrawn to the level of their respective tunnels to allow easy retrieval of them from within the joint space. We grasp the tibial wire first, followed by the femoral wire, securing them after we capture them. Next, we'll bring the graft loaded with the Pro-Cinch fixation device using the speed shuttle here to pass the first sutures and then pass the remaining sutures up through the femoral socket through the lateral incision. There are the flip sutures and the tensioning sutures. We will separate those out. The key to this is visualizing the button going up the tunnel and just clearing the outer cortex. Here we're once again separating the sutures, making sure we have the flip and the tension sutures separated. Now the button is passing up into the femoral socket. We'll visualize it passing just through the outer cortex. There we can see what appears to have breached the cortex. Now we're going to utilize the flip suture to flip the button on the outer cortex. This can be confirmed by tensioning on the graft. Here we can see that we had not fully flipped the button, so we will reposition and try again. We're tensioning the flip sutures, and once again, tensioning the graft. Now we can see the button is flipped and the graft is stable. We're going to start using the tensioning sutures that have eyelets to make sure we are pulling evenly on both limbs. We're advancing the graft through the gateway cannula up into the femoral socket. We'll make sure not to fully seat the graft all the way to allow for tensioning later. The graft has been marked at 20 millimeters, so we know the depth into the tunnel. We will now shuttle the tibial-sided sutures, once again using the speed shuttle to pass all of our remaining sutures. This is visualized from within the joint space, making sure the sutures are passing well within the joint space. Taking care not to have any of the sutures bind on themselves. Once again, going through the gateway cannula, there's a smooth transition of the graft into the joint space. Once the button is felt on the tibial cortex, then we can begin tensioning the tibial side using the Pro Cinch. Once again, the graft is marked at 20 millimeters to ensure appropriate depth within the tibial tunnel. Here we're going to do our final tensioning of the graft on the tibial and femoral sides to ensure satisfaction with the graft tensioning. There's the last tensioning on the femoral side to seat it fully within the tunnel. Thank you for watching our surgical technique video on STRYKER's VersiTomic RR.